Hello, thank you for having me here today. I'm Dr. Charles Ruotolo. I'm president of Total Orthopedics and Sports Medicine. I'm also an orthopedic surgeon and sports medicine specialist. And today I'm going to be talking about ACL ruptures, risk factors, and prevention. And the question here is, why is this important? And it's important because there's approximately 200,000 ACL tears per year in the United States, of which 70% of these are non-contact, meaning that it's not that someone ran into your knee, it's not that you had some collision that you couldn't prevent. It's that there was some type of technique issue of the way you cut, the way you came down from a jump, and some of these things where you're pushed off balance, but they're non-contact injuries that you could do some technique training to prevent. And importantly, females have a 4 to 6 times incident rate for ACL tears compared to males. So certainly with women, there is a big opportunity for ACL prevention techniques. So what's the significance of an ACL tear? Because we always hear about there's different people have ACL tears, you have surgery, they come back, they all seem to be great, but that's not always the case. And the biggest thing with an ACL tear is if you have an ACL tear, you're out for 8 to 12 months. It's a long period of time for a high school or college athlete. And then 30% of them have a chance of another ACL injury. So that's another 8 to 12 months. You know, this can be your entire high school or college athletic time could be spent rehabbing different injuries here. And high school females with an ACL tear have a 6 times higher risk of a second ACL injury within 1 year of return to sport compared to someone who hasn't had an ACL injury. It's a huge rate. And return to sport rates are not perfect. 83% of elite athletes get back to sport. That's almost 1 out of 5 that are not making back to sport. And when you look at amateur athletes, only 60% get back to sport, and 4 out of 10 are not making it back. And then the most important thing with this is ACL injuries increase your risk for arthritis. As soon as you have an ACL injury, you have done trauma to that knee that to a certain extent has changed the long-term course of that knee. And so when you look at someone with just an ACL injury, not a meniscus injury, not a cartilage injury, who's had an ACL tear, and then you have a patella tendon reconstruction, your risk of having arthritic changes at 10 years is 38%. Your risk of having arthritic changes on an x-ray at 20 years is 100%. And so you could be 16 years old, tear your ACL, and at 36, you're gonna have an arthritic knee. That's a huge difference in your athleticism throughout your life. And so you wanna prevent these before they happen. You certainly wanna prevent them from recurring. These can be devastating things that change the course of your life. So what's the mechanism of an ACL tear? The most common mechanism is a change of direction or cutting maneuver combined with deceleration. So you're going one direction, you put your foot down, you go to turn the other way, and as you do that, your hip adducts, your knee goes into valgus, or what we say kind of knock-knee position, and as your foot goes out and you tear your ACL. This is by far the most common non-contact way of tearing your ACL. The second most common is you're coming down from a jump, your leg is essentially straight at the same time as you kind of land on that leg. Your hip adducts, your knee goes into valgus again, your foot and your tibia are externally rotating as your knee goes in, you tear your ACL. There's a couple other less common ones, pivoting with the knee near full extension on your planted foot, your knee in a hyperextension, and in particular with skiing, falling back as your knee's in flexion, you're trying to hold yourself up. But the first two are the most common, and the first two, cutting, coming down the wrong way in a jump are things that you can work on to help prevent you from doing it, because it's technique driven. So on risk factors, there's a bunch of different risk factors. Some of these we can modify, some of these are not modifiable, but there's environmental risk factors, anatomic, hormonal, neuromuscular, and biomechanical. On the environmental side, it's really anything where there's a good grip. So dry versus wet for natural grass has a higher risk for ACL tear because you get more of a grip on the ground. So when you plant that foot, it plants. It's hot versus cold weather for natural grass or turf because the hotter it is, the better grip you have. It's artificial versus natural grass, which is why you have field turf now with all the little black pellets so that you slide a little bit more and you don't have as much of a grip. And it's Bermuda grass, which has a thicker thatch versus ryegrass. But what it all comes down to is grip on the ground, which allows you to kind of twist more and generate more force. On the anatomical side, there's a bunch of different things. One is, and especially with women, it's a higher BMI or higher weight. And there's 5 studies for this. There's 5 studies that show that it's no difference. But part of it, with weight, it's certainly the biggest thing is force is mass times acceleration. So you have more force when you're changing direction. Part of it can be biomechanical with someone who's a little overweight. And then the other thing is anatomic, because with women, their hips tend to be a little bit more wider. And then from there, your knees tend to be in a valgus position, which kind of sets you up into this position of risk. All right, so also on the anatomical side, there's a higher ACL injury rate with increased joint laxity or knee hyperextension. And so, one of the ways you tear your ACL is going into hyperextension. So if your knee naturally goes into 20 or 30 degrees of hyperextension, that can increase your risk. You also see it with excessive subtalar pronation of your foot, meaning that your foot turns out. And if your foot turns out more, that means that always pushes your knee in and puts you in that valgus position for your knee, which can twist your knee and tear your ACL. You also see, and this is a little bit more common in women, for having a small femoral notch. The femoral notch is the center of your knee where your ACL and your PCL are, and they're not all the same size. Some people have a wide notch, but some people have a very narrow notch. And if you have a narrow notch, as you twist, your ACL gets caught on the side of that notch, it can tear. And so one of the things we do at ACL surgery for people with a narrow notch is we'll widen that so that they don't have that problem down the line. But the other thing, it's been shown that if you have a small notch, you have a small ACL, and the smaller your ACL, the more easy it is to tear it. And then the last thing on the anatomical side is your tibial slope. And everyone's tibia, which is your leg bone, has a slight slope to it. The top of your tibia is not flat. It's usually about 5 to 7 degrees angled posteriorly, angled toward the back. But some people have a very high slope. It can be 10 or 12 degrees of posterior slope. And if your tibia slopes backwards like this, when you land, that tibia gets pushed forward as your femur kind of slides back, which pulls on your ACL. So on the hormonal thing, it's been shown that your anterior cruciate ligament actually has estrogen receptors. And because it has estrogen receptors, estrogen can cause increased laxity of your ACL. And so just to kind of review, there's 3 phases to your menstrual cycle. There's your follicular phase, which is the first 0 to 9 days, your ovulatory phase, which is 10 to 14 days, and your luteal phase, which is 15 to 28 days. And your pre-ovulatory, your first half has been associated with higher ACL injuries. And that's because you get increased knee laxity, especially during the ovulatory phase. And it has to do with that increase of estrogen. And then the important takeaway for this one is that oral contraceptives decrease knee laxity in one study and has been shown to decrease overall lower extremity injury in 3 different studies. And that's because it changes that difference in estrogen levels throughout that menstrual cycle. On the neuromuscular side, there's a couple important points here, but the overall thing here is that dynamic stabilization helps protect the knee joint during sports, and muscle actions have to be coordinated and co-activated, meaning that as you're doing things, you have to have strong quads and hamstrings. But it's not just that they have to be equal strength and that they're working together. It's that when you do something, your quadricep and hamstring have to fire at the same time. And sometimes you'll have this thing where you're kind of have a quadricep activation where it activates a split second faster than your hamstring, and then you have this big stress on your ACL. So hamstring recruitment reduces ACL loads from your quadriceps by pulling back on your tibia, and the quadricep muscle causes peak strain of your ACL at about 30 degrees of knee flexion. So just to kind of go over again, your ACL goes from the back of your femur to the front of your tibia. Your quadricep is pulling forward on your tibia, your hamstring is pulling back. So your hamstring, when it's firing, is helping protect your ACL. On the neuromuscular side, there's lower joint stiffness in females versus males. So you already have this leg that's kind of moving some and shifting some, which again puts you in that position of it's already kind of moving forward. You have this momentum as your quad's firing. And females have a higher quadricep to hamstring activation ratio. So you want to kind of work to reduce that. So plyometric training helps reduce peak landing forces. It increases hamstring torques. And you want to increase your hamstring to quadricep muscle ratio, which there's truly only one exercise that's been shown to change that ratio. You can do exercise to make your hamstring stronger and do exercise to make your quad stronger, but to change your quadricep to hamstring ratio, there's really only one exercise that's been shown to do that, which is this Russian hamstring curl or Nordic hamstring curl or Norwegian hamstring, whatever you want to call it. And it's an eccentric strengthening exercise where someone's holding your legs down, you're slowly moving forward, trying to kind of hold yourself up. At some point you fall forward and catch yourself with your hands. And this has been, you'll see this exercise in a bunch of different ACL prevention programs. On the biomechanical side, a lack of hip abduction strength, your hip abductors are here that hold your hips wide. That's been, or landing with your hip adductor has been shown to increase your risk because, if you're going in this way, that puts your ACL in that position of risk. A lack of core stability is also important because a lack of core stability increases your risk. And as part of that is when you're landing, if you're falling forward or as you're making a cut, you got to throw your body a certain way because you can't control your core because your core is weak. That increases your risk of ACL injury. And it's also been shown just athletes with low back pain have a higher risk of ACL tears than people without low back pain. And again, it has to do with that core weakness. A more erect posture during landing is associated with increased ACL injury, and for females, less hip and knee flexion angles are seen at initial landing compared to males after the age of 13, which is also the age where you see a difference in ACL injuries. And so when they're landing, they're not landing in this position that's absorbing force, and they're kind of landing with the legs more straight, which kind of puts them in these positions where their knee can twist and tear their ACL. So in a prevention program, to summarize this, what you want to avoid is this position of risk, which is you don't see it in this picture, but your upper body is forward flexed. You're kind of falling forward. Your pelvis can be kind of dropping to one side, and then as you're doing that, your hip, instead of being abducted, is adducted. As your hip adducts, your knee starts to point in as your femur internally rotates. At the same time, your foot is pronating and your tibia is externally rotating, and you tear your ACL, the two rotate in that position. So in a position of safety, you want your hip abducted, you want your knee in neutral alignment, kind of pointing forward, you want your foot in neutral alignment, and so your prevention programs want to be working on this. So this can be subtle, but as you look at this athlete, in this before in the prevention program, you see her pelvis is dropped here. From that, her hip is adducted, her knee is pointing in some, her knee is in valgus as well as her tibia is externally rotated compared to her femur. And on this, after the prevention program, you see her pelvis is more level, her hip is more abducted, her knee is pointing straight out, her foot's pointing straight out. And so this is what you want to get out of a prevention program. So there's a bunch of different prevention programs, and there's a lot to do. It's not that there's one perfect program, but in a prevention program, the most important things is one is you want to identify athletes at risk, because those are the ones that really have to spend a lot of time on this. Not everyone has to spend a lot of time on this. And then you want to work on core stability strength, hamstring activation strength, jump landing techniques, and balance training. At Total Orthopedics and Sports Medicine in Syosset, we have PhysiMax. It's a computer motion analysis machine. And what that is you do about a 40-45 minute thing where you're jumping off a box, jumping up and down on one leg. And it's looking at your stability, it's looking at your range of motion, it's looking at your strength, and it compares it to people of your same age and your stature. And what's nice is you get this printout of what your deficits are, whether you're weak in eccentric hamstring strength or you're weak in your hip abductors or in your core, what you biomechanically that you're doing wrong. But it also gives you a 9-week program, or these are specific exercises that you're going to tailor to yourself in its progression, where you do 3 weeks of this and 3 weeks of the next set, so that you can work on your specific deficits. Thank you for listening to my talk on ACL prevention. As you can see, this is a very important topic. You want to identify athletes that are at risk for ACL and get them in a program, and especially for athletes who've had an ACL injury, they need to be in a prevention program. They're at high risk, and there's certainly many different prevention programs that they can be working at, and there's a lot of different people that can help you with that, including what we use in Syosset is Michael Mejia at Base Sports Conditioning at the Sports Hub. And certainly these people can help you with your conditioning, help you in these prevention programs from having these drastic type injuries. Thank you.